Namaste Bitya. Hamisha khush raho Bitya. A very good morning to you all. Myself, JV and Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In this series of lectures, we have been discussing about the different type of genetic diseases. In the last lecture, we have discussed about what is gene, how the cell division takes place, what are the different type of cell divisions, and what are the different factors that are responsible for development of genetic diseases. I believe you must all have gone through the books and you must have studied what I have discussed yesterday. And you must all have answered the question that I have given in the keynotes. Now today we are going to start with another important genetic disease that is known as the Klinefelter syndrome. Klinefelter syndrome, this is a little bit common disorder that you are going to encounter. But this is also an important question from the examination point of view, because you are getting this question many times during the examination. So what is Klinefelter syndrome? What are the clinical features? How will you diagnose Klinefelter syndrome and how to manage the cases of Klinefelter syndrome? All these things we are going to discuss in today's lecture. So let's start with the Klinefelter syndrome. Klinefelter syndrome, what is it? It affects approximately 1 in 1,000 males. So it is a pretty common syndrome. This is not very much rare. So Klinefelter syndrome, it is affecting approximately 1 in 1,000 males, and it is usually associated with the 47XXY karyotype. So there is an excess of one sex chromosome. So normally we know that there are 46 number of chromosomes in an individual. Now, because of the improper separation, this we have studied in the previous lecture, how the chromosomes are separating and how the cell division takes place. So if there is an abnormal cell division and one of the chromosome is not separated during the meiosis, then what happens is we will get an extra chromosome, an extra sex chromosome that will result into 47 number of chromosomes. Instead of 46, the patient is having 47 chromosomes. And the most commonly it is seen as XXY karyotype. So there are other variations as well that we are going to discuss just now. So Klinefelter syndrome, it is associated with 47 number of chromosomes with XXY pattern usually. It occurs after the meiotic non-disjunction, as I have told you just now, that it is occurring due to the non-disjunction or the non-separation of the sex chromosomes during gametogenesis. So during the gametogenesis, there is non-disjunction or non-separation of the chromosomes. And this occurs with 40% during spermatogenesis and 60% during oogenesis. So from any one side, you can get a chromosomes without the separation of the, without proper separation of the sex chromosomes. So we will have more number of chromosomes than the normal. That is 47XXY. This is responsible from 40% due to spermatogenesis defect or 60% due to the oogenesis defects. There are also other chromosomal variants that you can see in case of Klinefelter syndrome based on the number of non-disjunction genes. So the more and more number of genes of non-disjunction you get, the more and more severity or the more and more number of chromosomes you will get ultimately in the individual. So the other chromosomal variants can consist of 48XXYY. So in 48, you are getting 2 number of extra sex chromosomes. So instead of X or XY, we are getting, because this is common in males, so XY will be there, and additional number of chromosomes due to the non-disjunction will add on it. So 48XXYY can be there. 48XXXY have also been reported, but these are less common. So in Klinefelter syndrome, what is happening is there is non-disjunction of the cell or the chromosomes during the cell division, especially the meiosis. And the defect can arise from the during the spermatogenesis or during the oogenesis. Now, what are the clinical features? What are the features with which a patient can present to us with Klinefelter syndrome? Now, as we have discussed, the incidence of this Klinefelter syndrome is around 1 in 1,000 men. Now, it is approximately 75% of the cases are not time lost. So, in majority of the cases, the condition is such it is not diagnosed because of the non-disjunction, and The features are not that much prominent in order to diagnose the case. But there are certain features that are present in the individuals. So it is characterized by small testes, because Klinefelter syndrome is seen only in the males, because Y component of the sex chromosome is present. So all the individuals are males. But despite of being a male, the sexual characters are not developed properly. So the individual of Klinefelter syndrome who is coming to you will present with the following complaints. The complaint of small testes. The testes will be smaller than the normal. There will be infertility. The individual will be infertile. So there will be small testes. The individual will be infertile. There will be complaints of gynecomastia. Gynecomastia is the abnormal development of breast in the males. So because of the chromosomal abnormality, since the patient is having more number of X chromosomes, so there will be development of the breast. So, but this is a male, potential male. So the condition will be known as gynecomastia. So it is characterized by small testes. There will be small testes with infertility. There will be gynecomastia, that is abnormal development of breast in males. The individual will be tall stature with increased leg length. The individual will be tall, but mainly the legs will be enlarged. So there will be tall legs in the individual, and hypogonadism will be there in the phenotypic males. So by the appearance, the phenotypic appearance of the individual is males, but the hormones will be less, and there will be hypogonadism, means deficient secretion of the hormones, especially the testosterone. So because of the X chromosomes, there will be development of the feminine characters, additional X character. So feminine characters will be there. The individual will have small testes. There will be infertility. The individual will be infertile, and there will be gynecomastia, that is development of breast in males. The individual will be tall statured with increased length of the leg. There will be hypogonadism with the phenotypic males. There will be developmental delay. The individual will complain of the developmental delay, and there will be different type of speech difficulties. So in the individual, there will be a developmental delay that you are going to see, and there will be speech difficulties and poor motor skills, especially in the adolescent. So the individual with Klinefelter syndrome will have a developmental delay. Although the individual is tall statured with increased leg length, but there will be a developmental delay. The individual will not be able to develop properly, and there will be speech difficulties. All right. So speech difficulties will be there, and there will be poor motor skills, especially in the adolescent. So there will be developmental delay. The speech difficulties will be there. There will be poor motor skills that will be observed during the adolescent. In the later life, body habit or infertility leads to the diagnosis. So the individual who is coming to you will be more or less normal. But as and when the individual grows further, then you will observe that the patient can come with the development of the gynecomastia, or there will be speech difficulties, developmental delay. But the most important thing that the patient can come to you will be the infertility. The patient will not be able to conceive properly. So later in the life or body habitus, the infertility will lead to the diagnosis of the complaint of the Klinefelter syndrome. The testes will be small and firm with median length of 2.5 centimeter, around 4 milliliter in volume, and almost always less than 3.5 centimeter, that is 12 ml. So these are the clinical features. The clinical features will consist of this is incidence is 1 in 1,000. Approximately 75% cases will not be diagnosed. They will be coming only for the infertility, and it will be characterized by small testes, the presence of small testes. There will be infertility. There will be gynecomastia. The individual will be tall, statured with long leg length. There will be hypogonadism, and the patient will be phenotypic male. So hormone level will be less, especially the testosterone. There will be developmental delay with speech difficulties and poor motor skills that the patient will get developing during the adolescence. And in the later part of the life, the body habitus or infertility will lead to the diagnosis. So in the later part of the life, the infertility, due to the infertility, you will be able to diagnose the case. The testes are smaller and firm with median and are always less than 3.5 centimeter. So how to diagnose a case of Klinefelter syndrome? Whenever a patient of Klinefelter syndrome, if you are having a suspicion that the given patient is of Klinefelter syndrome, then how to diagnose such cases? So first of all, we have to check for the plasma concentration of the follicular stimulating hormone and luteinizing hormone. These are both increased in most of the adults, and plasma testosterone is decreased. So because of the hypogonadism, because of the increased X chromosome, FSH, the level of the FSH and LH will be increased, whereas the level of the testosterone is decreased. The level of estradiol or the estrogen is often increased. So the female hormones, that is the follicular stimulating hormones, the luteinizing hormone, and the estradiol or the estrogen is usually increased, whereas the testosterone level is reduced. A typical phenotype in the patient with hypergonadotrophic hypogonadism can be confirmed by karyotypic analysis. So at the end, you can go for karyotypic analysis. So if you need to confirm the diagnosis, then karyotypic analysis is the most important and confirmatory diagnostic test for Klinefelter syndrome. So how to diagnose a case of Klinefelter syndrome that is coming to you? First of all, you can check for the hormonal levels. Plasma concentration of FSH and LH is increased, whereas the testosterone level is decreased. The estradiol level is increased. And the typical phenotype of hypogonadotrophic hypogonadism, it is confirmed by doing karyotypic analysis. What is karyotypic analysis? By karyotypic analysis, you can see the genetic composition, whether it is 46XY or 47XXY or whatever, 48XXYY, whatever the genetic composition can be. That is not normal. Now, how to manage such cases? If a patient of Klinefelter syndrome is coming to us, then how can we manage such cases? There will be growth and endocrine function and normal bone mineralization. It should be monitored because of there is developmental delays in such individual. So we have to monitor the growth of the individual. We have to check for the endocrinal function because testosterone level is decreased, FSH, LH, and estradiol is increased. So we have to monitor the endocrinal function, especially from the adolescents. So if you are having a suspicion, doubt of Klinefelter syndrome, then you have to monitor all these things: the growth, the endocrinal function, and the bone mineralization. Education and psychological support is very important in the patient with Klinefelter syndrome, because we know that in the genetic disorders, nothing can be done. The individuals with clinical and biochemical evidence of androgen deficiency require androgen replacement. So for the complaints like gynecomastia, hypogonadism, we can do hormones replacement or the hormone supplementation. Androgen supplementation improves virilization. So the voice that is changed due to the excess of the female hormones, androgen supplementation can be done, and this will improve the virilization. There will be increased libido and energy with hypofibrinolysis and bone mineralization in men with low testosterone level, but may occasionally worsen gynecomastia. So androgen replacement will ultimately improve the condition, but it will worsen the condition of development of gynecomastia. So in androgen supplementation, there will be virilization, the improvement in the virilization, the libido, the energy, the hypofibrinolysis, and bone mineralization, but it will worsen the condition of gynecomastia. Gynecomastia can be treated by surgical resection and liposuction. The fertility is achieved by using in vitro fertilization. So in such couples, in vitro fertilization can be done in the individual with oligospermia or with the intracytoplasmic sperm injection after the retrieval of spermatozoa by the testicles, sperm extraction techniques. So in the management, what you are doing, you are monitoring for the growth, endocrinal function, and bone mineralization from the adolescents. Education and psychological support is very essential, and it has to be given. The family and the friend supports. An individual with clinical and biochemical evidence of androgen deficiency, they require androgen replacement. And androgen supplementation, it improves the virilization, libido, energy, hypofibrinolysis, and bone mineralization with low testosterone level. And gynecomastia can be treated by surgical resection and liposuction. And fertility is improved by in the individual with oligospermia through the in vitro fertilization. And this is about the management. Now, there are certain complications that you can see with the Klinefelter syndrome. In the individual with Klinefelters syndrome, there can be increased chance for development of breast cancer. There can be chances for development of the cardiovascular diseases. Different type of metabolic syndrome can be seen in such cases, and these can be the victim of different autoimmune diseases. So in the complication, we will have breast cancer, cardiovascular system disease, metabolic disease, and autoimmune disease. So this is all about the Klinefelter syndrome. I believe you must have understood this session properly. For more information, you can consult your book and the e-notes that I have uploaded on the portal. So this was all for today. In the next session, we will be discussing about more genetic diseases. So this session is powered by digital version 2.0 JAYOTI VIDYAPEETH from its university. I hope you must have understood the session properly. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Just go through the e-notes and try to answer the question that I have given to you. So this was all for today. Thank you very much. Have a good day.